Hello! The following video is to inform you about the agitation rating scale pilot being initiated on 3rd floor at Seton Shoal Creek Hospital. The purpose of this pilot is to assess if the use of an agitation rating scale to assist in nurse-to-nurse and nurse-to-physician communication. Clear and complete communication may improve agitation treatment planning and thus decrease emergency agitation situations, which lead to code grays and restraint episodes. If successful, implementation of this tool may also assist in optimizing PRN medication regimens, minimizing documentation related to agitation episodes, and customizing patients' treatment plans. By the end of this video, you will familiarize yourself with the agitation rating scale form, walk through the process flow diagram, view 2 patient cases, and identify key project members for questions regarding this pilot. This is the pilot for the Modified Overt Aggression Scale, or MOAS. The MOAS is a 4-part behavior rating scale designed to measure 4 types of witnessed aggressive behavior. The scale has been validated for use in the inpatient behavioral health setting since 1988. The scale assesses verbal aggression, aggression against property, aggression against self, and physical aggression. The severity of each category is rated on a 0 to 4 scale. The rater should select the most appropriate description in each category, then transfer that score to the table below. Each category is then weighted to produce a weighted episode. The scale provides a common terminology for communication of an agitation event. Utilizing the scale before and after an acute event can provide a picture over time of a patient's aggression symptoms, effective and ineffective interventions, and agitation progression or resolution during an admission. On the back of this form is a flow diagram. Use this as a reference during the pilot regarding when and how to use the agitation intervention tool. For purposes of this pilot, the agitation rating scale form should be used during an emergency agitation event. While you could use it during any episode where an agitation event is required, no matter how mild or severe, we ask you to use this in events where an active intervention order is not enough to control the situation and updated physician orders are needed. To explain how to use this form and flow diagram, please watch the group complete the following examples. All right, everyone. This is the agitation rating scale form, and this is the flow diagram on the back. Let's go through a couple examples to familiarize yourselves with these documents. Are you ready for the first example?
Sure.
Jane is a 34-year-old female on day 1 of her admission for schizophrenia. At this point, the treatment team has not seen her, so you only have the admission orders including PRN olanzapine 5 mg PO. Over the last 2 hours, Jane has been escalating from periodic shouting and pacing to threatening staff and slamming doors. You've already given her both olanzapine 5 and hydroxyzine 50 mg PO about 50 minutes ago, with little change in her behavior. She pushes another patient, so you call the attending for emergency agitation orders. While the treatment team arrives, how would you fill out the column 1 on the MOAS form?
I selected a score of 3 on the verbal aggression and 1 on the aggression against property.
I also selected 2 on physical aggression. I didn't select anything for autoaggression at this point.
Good. Based on the table at the bottom of the column, what's your total MOAS score?
Verbal aggression score of 3 times 1, which is a 3. Aggression against property, a 1 times 2, which is a 2. Autoaggression is 0, and physical aggression is 2 times 4 equaling 8. Together, those make a 15.
Great job. Enter those values in the sum boxes and you have a completed scale to share with the treatment team.
That's great. But do we have time to do math while a patient is experiencing an agitation emergency?
That's a great point. So what took the longest part of filling out the form for you?
The scoring box on the bottom took the longest for me.
Me too. Checking the items on the scale didn't take more than a few seconds. It's the scoring that we don't have time to sit and figure out in real time.
Agreed. Since this agitation scale and form is new to everyone, the score itself really doesn't add much to the conversation at this point, but the descriptors and severity of agitation does. If you utilize those few seconds to complete the severity of those 4 items and share that with the physician, that will add much more clarity to the conversation regarding your emergency agitation intervention needs.
Great, so we have this form in the treatment team. Then what?
So, like any other agitation emergency, update the team on what's going on, including the form, which could be read or shown to the team.
I see. Now that we have this form with agitation descriptors, we can use this in our status reports. This gets us all on the same sheet of paper when describing agitation events and saves time on trying to find the right words to explain the situation.
Exactly.
This could really save us time in both physician report as well as shift change report.
I was thinking the same thing.
Good, now you have the idea. Okay, let's go back to our case. So we received order for Jane based on the information you put in column 1. The attending ordered Haldol 5 milligrams, Benadryl 50 milligrams, and Ativan 2 milligrams, all PO, all once. You get those medications to the patient immediately, then transcribe those orders to both the MAR and the bottom of column 1 on the MOAS form.
Wait a minute, I have to document those orders in 2 places?
Yes, unfortunately during this pilot, we are asking that you please document those emergency interventions in both the MAR and the pilot form. We understand this is not an ideal situation, but while we test the effectiveness of this form, we ask you to assist us by double documenting while we collect this data.
But we don't have to do this forever, right?
Oh, no, not at all. This pilot is scheduled for 4 months of data collection. Once it's over, we will either start the process of making this a permanent chart form or just remove the document. Either way, at that time, you no longer need to document in 2 places. If effective, this form could decrease documentation in several ways, including a single place to document the description of the agitation event and the effectiveness of the intervention.
Okay, that makes sense. So I put the Haldol, Benadryl, and Ativan with the time and date on the form. Now what?
Now you assess the intervention after 1 hour or what could be a reasonable period of time to see if the intervention took effect. In column 2, you document your observations. So for this case, you find in an hour after the medications are given, Jane is still cursing mildly. But now she's in a room. She still makes menacing gestures towards one patient in particular, but only when that patient approaches her personal space. Otherwise, she leaves others alone. How'd you fill out column 2?
I checked 1 for verbal aggression and 1 for physical aggression. That gives me a total MOAS score of 5.
Great. So do you think the intervention was effective? Do you need further orders?
Yes, I'd say the intervention was effective, but I'd like the staff to know the issue between her and the other patient.
I agree.
I agree too.
That would definitely be important information to hand off. After you sign, date, time the form, you'll file the document in the medications tab of the patient chart.
So you keep it where the previous day's MARS and PRN sheets are?
Yes, then anyone in the treatment team can review this form to assist in identifying agitation trends or triggers. You can also use this form's descriptors to fill out your care notes and discuss shift-to-shift handoff.
Well, that all sounds good, but will the treatment team know to look for them? How will you collect data if they're sitting in the chart?
Great questions. Communication regarding this project has gone out to all attendings. They know to expect discussions using the form. Members of our work group will be periodically reviewing charts for data collection. Also, once a patient is discharged, medical records knows to remove these forms and documents and save them for our team. Are you ready to move on to the next case?
Sure.
Great. So Sam is a 48-year-old male, admitted for an acute manic episode. He's on day 4 of his stay and refusing all medications. He's set up very easily and has temper outbursts throughout the shift. He's been destroying items in his room and attempts to throw furniture during his outbursts. The CA grabs your attention because he began banging his head on the wall. When a CA attempted to coax him to stop, Sam pushed him violently against a table, injuring the CA's wrist. What do you do next?
Oh dear. Well, first I'm going to call it code gray. And since he's refusing meds, I'm going to call the team for some IM meds.
That sounds good. Do you have a couple seconds to fill out the 4 items on the form?
I already did. I gave a verbal aggression score of a 2, aggression against property a 2, autoaggression a 2, and physical aggression as a 3.
Very good. Does that seem reasonable to have this prepared for the status discussion? Remember, you don't necessarily need the scoring to be complete.
That seems reasonable, but I did complete the scoring and got a MOAS score of 24.
Wonderful. Over time, this will become much more fluid as you familiarize yourself with the form and the scoring. So the resident happens to be on the unit. You share the form with them and he orders olanzapine 10 milligrams IM once. Now what?
First, I administer the medication since I have the team there to assist me in giving this injection.
Good.
Then I document the olanzapine and the MAR and the form, date, and time.
Great. Okay, so an hour later, Sam is still pacing. He's shouting. He's throwing furniture. As a patient walks by the room, he jumped out of his room and pushed a patient into the wall. Was the intervention effective?
I'd say no.
I've already marked column 2 with verbal aggression score of 2, property aggression score of 2, auto aggression I left blank, and physical aggression of 3. I call jumping out of his room an attack.
Yeah, that gives you a MOAS score of 18. Is that resident still around?
Yes, he is. So what do you propose?
I think I'd emphasize the physical aggression and aggression against property are still the most alarming. He needs more than a single shot of olanzapine.
Good. Did the form help you organize your discussion points for the provider?
Yes, it does, but there are only 2 columns. What do we do with this next intervention?
That's a great observation. Based on the flow diagram on the back, you basically would start this over again.
So you keep doing this over and over?
Depending on the agitation episode, yes. But you should start seeing a clear picture of what the key agitation symptoms and what interventions are or are not working. Does that make sense?
Yes. Okay, so we complete column 2 on the first form. What do we put in column 1 for the next form?
Good question. Column 2 on the previous form is basically column 1 on the new form. You could either transfer your work or just put your intervention at the bottom of the column on the new form and say see MOAS form. I'd encourage putting the score at the very least. Let's say the provider decides to order Haldol 10 IM, Ativan 2 IM, and Benadryl 50 IM.
Okay, so that goes on the bottom of column 1 of the new form with the time and date. Based on the time and date, that will correlate with the previous MOAS form, so anyone viewing the chart can see how this event progressed, right?
Exactly. So 1 hour later, Sam is in his room. He's lying down, he's cursing when staff come into the room, but he's not attacking anyone or damaging property.
I get a MOAS score of 1.
Me too. I'd say that was effective.
Good. So how do you close out this episode?
Sign and date both forms. Place both forms in the medication tab of the chart.
I'm also going to use these forms to fill out my care notes while my patient is still sleeping.
Very good. Well, that's it, and it sounds like you understand the process. Do you have any other questions?
I have one. While this process worked for your case examples, what about other things that come up we haven't learned about or this work group didn't think about? What do we do then?
Great question. This is a pilot. We know there will be feedback and questions, and we encourage you to bring those questions and ideas up to make this process and tool more effective. You can contact anyone on the work group for feedback. Melissa Lewis in pharmacy, Dr. Linda Funderburg and Dr. Tawny Smith in psychiatry, Doug Schwartz and Ann Wilson in nursing, and Michelle Ding as a pharmacy resident. All can assist you with your questions and feedback.
2 other questions. When did you say this pilot will take place, and how long will we know it's going, and how will we know it's going?
Excellent questions. This pilot will start December 8th and it will run through March 31st. There will be a dashboard on 3rd floor nurses station with background on the pilot, a timeline of our progress, a graph of monthly seclusion and restraints, and the number of forms identified by the data collectors. Since the point of this pilot is to measure feasibility of incorporating the scale into workflow, there will be a nurse and physician satisfaction survey at 2 months in and then again at the end. Those results will also be added to the pilot dashboard.
Sounds good. So where do we find the forms when we need them?
Very important. Forms will be in a pocket in the dashboard area. Please let any team members know if you are running out of forms. The group will be reviewing and updating and replenishing this dashboard regularly. Also, since this is a pilot, this is our form of education. We have a short turnaround time and kickoff for this project, so please share what you've learned with your 3rd floor colleagues so we can make this pilot a success.
Sounds good.
Thank you for your time, and please contact anyone in our work group for questions or feedback.